Hello, everyone. Good afternoon, good morning, good evening. Welcome to another Residency VMR, CP Solvers here. We have a very special session today because we have a case presenter, Dr. Francisco Alexandrino. He is a member from CP Solvers that matched last year into Cleveland Clinic. We're so proud of him, and he's coming again with his team. Would you like to introduce yourself, friend?
Hi everyone, my name is Francisco. I'm so excited to be here presenting a case, seeing friendly faces. Thank you so much for this opportunity. And yeah, I love sports in general. So on my free time, I do medicine. That's what I usually say. And yeah, I'm so happy to be here with also two curriculum chief residents, Mo and Ian, and also our PD, Dr. Bertano, will also join shortly. So
Yeah, we're very happy to have you here. Who's your favorite team? Share with us.
my favorite team.
Yeah, soccer team.
So it's of course the one and only Sporting Lisbon. Now I started supporting Cleveland Cavaliers. Now, of course, have to find the second best.
Definitely, definitely. Oh, it's the Dr. Retanu.
Hi, good
Hello.
afternoon, good morning, everyone.
Hello, Dr. Retanu. Thank you so much for joining us. We were here introducing our case presenter, Francisco. We are so proud of him for his great job. Would you like to introduce yourself and share with us something you like to do outside of medicine?
Sure. So first of all, thank you so much for inviting me. I think you guys do a phenomenal job. I saw some of your podcasts and they are absolutely phenomenal. I'm glad our residents are involved in outside. So I'm the Andre Bretano, I'm internal medicine. I'm the PD for the CCF internal medicine residency program. I do both inpatient, outpatient medicine. Actually, I'm on service now. I just finished rounding. And I know my senior is also logging in to see. Francisco is actually my intern this week, so that's phenomenal. It's another reason for me to join. So what do I do outside? I'm an Uber for my kid. I take her back and forth to school for all her activities. Yesterday they had the Beauty and the Beast. Actually, was absolutely phenomenal. I'll show the residents some of the video clips. I love music, and I love all kinds of music, but I love classical music. And here in Cleveland, we have one of the best orchestras on the planet. So we go there whenever we have time. I pretend I know how to ski, so I went a few days ago and I injured my MCL. But no, I'm okay. I'm alive, so it's all good. So yes, and obviously spending time with my family, with my kids. Cleveland actually is a beautiful place, especially spring, summer, fall. The winter is getting warmer. In a few days, we'll have, I don't know, minus 20 or something like this, but the rest of the year is good. So thank you again. That's awesome.
Thank you so much. Yeah, San Antonio here is not that nice the winter. We still have like the temperature just a little bit colder. So of course we have to bring out all the sweaters. But thank you so much for sharing that with us. And we also have Dr. Mohammed. By the way, if I said a name wrong, please feel free to correct me. Dr. Mohammed Alamer, thank you so much for being here. Would you like to introduce yourself and share something fun about you?
Of course. Thank you so much for having us with you today, and thank you for inviting us to this episode. We're very, very proud of Francisco, and we're sure he's going to present an amazing case for you to go through. So my name is Mohammed Alamir. I'm originally from Jordan. I went to medical school there, graduated in 2017. I then came to the Cleveland Clinic here for my internal medicine training. Where I trained with Dr. Brutano, actually, and many other amazing educators here at the clinic. After completing my medicine training, I stayed here for another year, which I'm currently doing a year of chief resident. I'm one of the curriculum chief residents. My counterpart in curriculum is also here on the meeting, Ian. And next year, I'm going to be starting my cardiology fellowship. And outside of work, I enjoy a lot of things. I generally I'm a generally active person. I like to do sports, but I haven't been doing a lot of that because I have a 1-year-old now, so that's what I do when I'm not working currently. I spend time with my daughter Noor.
That's really nice. And thank you so much. And congratulations for mentioning cardiology. We know that here Francisco is also like a cardiology enthusiast. And Dr. Ian, would you like to introduce yourself and tell us something? What do you like to do outside of medicine?
Yeah, good morning, everyone. Thank you so much for inviting us. This is really excellent. I'm sorry I'm not dressed with Biffy as Dr. Bertano and Dr. Alamar, who are both on service. I am home with both of my children right now, and in order to negotiate an hour away to do this, I had limited time, so I had to put on whatever I could. So I do apologize for that. Francisco is amazing. I've worked with him multiple times on the inpatient and outpatient services, and I'm sure he's going to do amazing. I am originally from New York, pretty much spent my entire life there. Went to undergraduate there at NYU, medical school in Long Island, and then convinced my wife to come to Cleveland. While we were here, we went from just 2 people to now 2 children, a dog, and we are moving back to New York for cardiology fellowship. So we are coming back home with an army. Mohammed is my Jordanian twin. He is like me in every single way, just smarter and probably better looking. But really, we have a fantastic team at the Cleveland Clinic, and we are so happy that Francisco joined us and can share some of the good cases we have for you.
No, thank you so much. It's becoming a very family-friendly VMR today. That's very lovely. Moving on to, we also have a Jordanian team member here. Suzanne, would you like to introduce yourself? She's one of our case discussants today.
Hi everyone, I'm Sosan. I'm a medical graduate from Jordan, and I'm interested in internal medicine, and I'm happy to share the space today with Dr. Ravi and Johan, and looking forward to Francisco's case.
Awesome. Johan, would you like to introduce yourself today?
Of course. So, hi everyone, I'm Johan. I'm from Cameroon and I went to med school in Morocco and I'm currently based in Barcelona. I'm so excited to discuss this case with Tausan and Dr. Ravi.
Thank you so much. And last but not least, our dear Dr. Ravi, teacher, mentor, and guidance here in CP Solvers. Dr. Ravi, would you like to share with us?
Oh, thank you for that warm introduction. Happy Saturday, everybody. Welcome Cleveland Clinic program to CPS. I'm a member of the fan club of Sosan and Johan, so very happy to be here and back them up, but they will take it away with today's case. And good to see you again, Francisco. We were sort of thinking about our ChatGPT session long ago with Robbie. So hope everybody has fun. So welcome.
Definitely. And okay, so we can start the case whenever we're ready. And just as a little heads up, at the end of the session, instead of listening to our amazing Mina Hill with her teaching points, we have a little Q&A session with the residents and of course Francisco to talk about their experience and how much they learn at Cleveland. So thank you so much. Francisco, whenever you're ready.
Sure. Okay, let's get started. So we have a 53-year-old female that presented to a methadone clinic with unknown duration of generalized weakness and altered mental status. You can discuss.
Should I go first? Okay. So we're having a 53-year-old female who presents with generalized weakness and altered mental status of unknown duration. So these are two generalized symptoms. Like generalized weakness can be due to a lot of causes. And with the altered mental status, we usually, especially if it was acute, we usually think of the missed mnemonic, thinking about metabolic causes, infectious, toxic causes, and structural causes as well. So with the unknown duration, I'm not sure how can we approach this, but coming to the methadone clinic, I think is something we have to look for, or it's a hint for what could be the underlying cause. So Johan, what do you think?
I completely agree with you. I mean, when I see generalized weakness in AMS, I will first focus on AMS since, I mean, it's more specific of something happening in maybe the brain or the metabolic. So I generally go with the mixed mnemonic as well. So as you said, metabolic, infectious, structural, and toxin. And in general, I would say the HPR will give us more information, but regarding the generalized weakness, I mean, there is a chance that it's not necessarily linked to it, but overall, for now, we'll link it to the altered mental status as well. And the fact that the duration is unknown, I mean, it makes it harder to build a sort of time frame to narrow down the diagnosis. So I would love to know more in the HPI. What do you think, Dr. Ravi?
I think both of you are doing a fantastic job. This is going to be something you're going to see in residency quite a bit. So I was just on service and I had multiple patients. Actually, I was rounding with Ibrahim and he had 2 or 3 altered mental status patients. So the Mr. Mnemonic is a gold mine. It is absolutely wonderful to use as a starting point to try and break down what's going on. So, but a few things as a practicing hospitalist, what I'm worried about before this is the patient stable? Of course, you want to do the cognitive legwork and try and figure out like what is causing this altered mental status. But I want to make sure also before I start doing that brain cycling, trying to figure out or solve the problem, is this patient stable or not? So is this patient protecting their airway? Do I need to intubate? This sort of harks back to a patient I had. I was doing the same thing. I was trying to figure out what was going on with the patient, but then I'm like, wait, what if this patient can't protect their airways? So I'm forgetting a very important step. Number 2 is this something that I can rapidly correct? So you're in a methadone clinic. What if there's other substances involved? So maybe giving a dose of Narcan, which is readily available in these facilities, maybe reverse the process. Of course, you want to start doing an evaluation of the patient. You also want to do a quick finger stick. I run rapid response simulation with residents, and sometimes in the heat of the moment, the epinephrine is running and you try and figure out what's going on. And a lot of times it takes 10 minutes for somebody to think about, hey, what about the glucose? Very easily fixed. So also doing a finger stick and at least seeing if that is one of the causes. And once you stabilize the patients, you got the vital signs and everything, checking airway, breathing, circulation, then you start doing the cognitive legwork as to what's going on. And then also transferring this patient to the emergency room as soon as possible and in a safe manner. Anything else comes to mind, Solsan and Johan? You're doing an absolutely splendid job.
Not really, but I think, yeah, stabilizing and checking if the patient is stable or not is something very important.
Okay, on to the next aliquot, Francisco.
Great thoughts, great discussion. Amazing. So let's move on. So the patient was refilling her methadone for chronic dependence, and she was noted altered. She was only oriented to person, and as such, EMS was called and she was brought to the ED. When the patient was left alone, she desaturated to the 80s. So we had like to shake her and she would respond to voice. She would open her eyes and she would reply, and then her sats would go to above 95. She denied any chest pain, abdominal pain, nausea, dizziness, shortness of breath. Overall, she was a poor historian, but she looked fatigued, tired, but not in apparent distress or pain. And now I'm going to say the vitals because, as Dr. Ravi said, it's very important to make sure that the patient is stable. And their blood pressure was 98/53, heart rate of 95, a respiratory rate of 8. The EKG was normal. UTOX was negative. And I think I can give you briefly the past medical history and social history. Upon chart review, she had treated hepatitis C, minimal change disease in remission, drug-induced lupus to lavimazole, depression, history of polysubstance use, morbid obesity, hypertension, diabetes, and chronic opioid dependence. She lives with her mother. She's unemployed. and denies consuming other drugs. In terms of meds, she was taking basically just methadone. We saw valsartan and metformin with very poor compliance, and she was not taking them at the moment. And maybe I can stop here and you guys can go ahead.
Johan, you want to start this time?
Yes, of course. So I mean, wow, what a twist. And I think we already have a lot of information. Thank you, Francisco. I think the fact that the patient is desaturating to the 80s and that it can be almost get corrected when active, I mean, push me more toward maybe an opioids intoxication. So I'll also like to know if the patient received Narcan, for example, or if I mean the workup we were talking about to rule out the most acute causes like finger stick, glucose, etc. was done. So overall, for now, I'm leaning toward that. And regarding the past medical history, I mean, she has a rich past medical history with drug-induced lupus. I don't know what drug exactly she was taking and why. And the chronic opioid dependence, which is important as well regarding the overall presentation. And a part of that for the physical exam, well, the blood pressure is a bit on the lower side, but as of now, the only information that I get here is the saturation, which is really concerning. So I'd like to have the blood gas as well to get more information and really to know if the patient was, for example, given Narcan or any other thing to see if it corrects her condition. What do you think, Sausan?
Oh, yeah, I completely agree with you. Wanting a VBG right now just to see if this patient is hypercapnic as well. And just seeing how she has like low respiratory rate and she has hypoxia. She's desatting, and could this be like giving us a hint to look into the lungs? Maybe there's an infectious cause, like, or an underlying process that was brewing for a while, maybe as well. Especially that the patient has it's treated hepatitis C. Yeah, so I feel like just having like a focal exam, looking for a focus, trying to see what's causing the hypoxia and if there's a hypercapnia as well. What do you think, Dr. Ravi?
Oh, I think everything that you guys are thinking. I think just you're laying out such a wonderful pragmatic approach in that you've taken the data and really pinpointed what is crucial in trying to solve this problem. So you focused in on the respiratory rate, ideally, and a respiratory rate of 8. You're like wondering, hey, could this be an additional substance that could be causing this? So of course, I would not even hesitate to maybe administer Narcan in this situation. But sometimes you don't want to miss the forest for the trees and try and think, is there some additional process and not just narrowing your focus on maybe substance use disorder. Sometimes I kind of want to pause when you go through these situations. You want to be very objective and not subjective. So just hearing the term, sometimes we just latch onto it and anchor substance use disorder. But hey, anybody that's suffering the ills of substance use can have any number of different disorders. So you have to start thinking about, is there something cognitively going on? Is there something such as a stroke or some other vascular process that could be causing this, rather than just kind of latch onto the substance and just be so subjective with the patient. But obviously this patient is in a terrible situation with this, but we have to then remain neutral and treat the patient just like any other patient that comes across our list. So yeah, I think pretty much what you have mentioned. I know with methadone, I'm kind of interested in the EKG, because methadone does cause QT prolongations, especially if there's additional medications that are taken that could further prolong the QT interval. But that's all I have to say at this point. I think definitely, like Sausan said, getting an EBG would be crucial to see what the A gradient is, and also then imaging the chest to see if there's something that's developing within the chest. Anything else comes to mind, Sosa and Johan? All right, I guess we'll move on with Francisco to the next aliquot.
Great thoughts. So you are one step ahead. So basically, as you said, the patient got Narcan for a suspected opioid intoxication. VBG was unremarkable. Chest X-ray didn't show any infiltrates. And on physical exam, the patient, as I said, looked unwell, fatigued, but no apparent distress. ANO ×1, only oriented to person. Skin was warm, no rashes, but mucosa was pale. Ear, nose, and throat exam, unremarkable, no rash. She did have constricted pupils. And in terms of palm, no accessory muscle use, was clear to auscultation, equal bilaterally, S1 and S2 regular, no murmurs, 1 plus pulses, 1 plus bilateral, radial and dorsal PDs, abdomen, it was obese, distended, non-tender, with mildly decreased bowel sounds. Musculoskeletal, no swelling, some generalized weakness. And neurological wise, the patient was irritable, but with no focal neurological signs. I would say 4 out of 5 strength in all extremities with preserved sensory function. She was in bed, and we couldn't ambulate her to assess her gait. I think I can also move ahead with some labs. So white blood cell count was 7.5, and hemoglobin was 2.2. And once these results was seen, the patient was immediately transferred to the NICU, and 4 units of blood were ordered. So hematocrit was 7.1, MCV 106, platelets 19, RET count 5.7, which is elevated, but the reticulocyte index was 0.39, showing a hypoproliferative anemia. Albumin 3.5, total bilirubin 2.2 with a direct of 0.7. Alk phos AST ALT normal. Creatinine was 1.89 from a baseline of 0.9. So electrolytes, no changes, all within normal limits. Aptoglobin was below 10, LDH 2500, troponins were flat, and there was 17, 20, and 19, Coombs negative, and the UA was unremarkable without any signs of proteinuria. I can also show. I can also copy the labs in the chat, or I'll copy them for make it easier. And yeah, go ahead, guys. Some interesting data here.
Very interesting, Francisco. Solsan, you want to start this time?
Sure. So with the exam, I can't see anything other than the pinpoint pupil that is concerning. But for the labs, for the very low hemoglobin and platelets, so we're having bicytopenia, and the MCV was elevated, Francisco. So I don't know if this, does the patient drink alcohol, for example? Could she be like, I want to think also of vitamin B12 deficiency being a cause for the cytopenia. Having a reticulocyte index that is low is also concerning. I want to check, I want to have a peripheral blood smear as well for that. And I feel like the creatinine is showing, the elevated creatinine is hinting towards a pre-renal, maybe kidney injury or something related to the anemia or like hypoperfusion that we can link with the pinpoint pupils. Maybe like I'm not sure if we should get a CT scan, but I think I would for now. Honestly, I'm still trying to connect the dots right now. What do you think, Johan?
Well, amazing, Sausan. What an interesting aliquot, Francisco. So I'll start talking about the anemia, and I agree with Sausan. We definitely need a peripheral smear to see if maybe we have schistocyte or if we have, I mean, anything different than that. But when it's come to anemia, my thought process is simple. Well, is it something extrinsic, like a MAHA that is basically crushing the hemoglobin, or is it something intrinsic, like a bone marrow problem? Or, for example, sickle cell disease that will lead to, or G6PD, for example, that will decrease the hemoglobin in an intrinsic way. So when I see the labs and I see that the aptoglobulin is low as well and the bilirubin is high, I'll start thinking about, okay, like there is some sort of hemolysis, extravascular hemolysis going on. And the fact that the creatinine is high as well and the platelet is low and the patient has altered mental status make me think right away about TTP on my differential that will cause MAHA and low platelets as well. But the fact that the reticulocyte index is low at the same time is counterintuitive, right? So if there is MAHA, you will think that, okay, maybe the reticulocyte count will go up, but it's going down in this patient. So we cannot rule out for now like any liquid malignancy without having the peripheral smear to just double check if we have schistocyte, for example. So, and the LDH is elevated as well. So, I mean, that's overall my thought process for now. Go through my anemia schema. And regarding the PE, pinpoint pupils, well, I think, I mean, I don't know if it's specific for any condition, but the fact that the skin is warm as well, and there is no sign of infection whatsoever. I don't know what the temperature is, but the WBCs are normal. I mean, it might be a sign of intoxication of maybe something else, of maybe a cholinergic product, I don't know. But overall, for now, my focus will be on the anemia since it's really low. The hemoglobin is so low, and go over my anemia schema and thought process. What do you think, Dr. Ravi?
Well, I'm just enjoying your discussion. I think both of you have put a very competitive argument for one of these disorders, so one of these MAHAs that you had mentioned. So you've picked up on the breadcrumbs that there's something systemic going on, and the fingerprint is in the hematological system. But then you do kind of have to look outside because, like you mentioned, there's many causes, and it's interesting. I usually teach, okay, when we teach anemias, we talk about hemolytic processes or bleeding, or if there's compartmentalization of blood within a specific compartment of the body, that usually the retic count is high, but you astutely picked up that retic count is low. So it's very kind of concerning. There's something going on maybe within the bone marrow should respond, right? So EPO should kick up and then reticulocyte count should increase. So when following or sort of hanging on to your coattails with this argument, I'm kind of wondering, okay, what kind of conditions? This is not an immunological hemolytic anemia, so the Coombs test is negative. So we have to then focus our attention to the hemolytic anemias, namely TTP, HUS, atypical HUS. Could this also be DIC, or could this be a RBC issue, like you mentioned, G6PD, sickle cell disease, and so on? Even infections could cause a massive hemolytic anemia, like malaria, leishmaniasis, and so on. But here, I think it's crucial to sort of see, with the platelets being that low, it's usually typical more so, but it's not a concrete argument that it's TTP. The altered mental status, we always have you remember for step one, the pentad, right? So AMS is within there. The platelets are significantly decreased in this case, which is more typical for TTP. I think here doing a plasmic score and then also getting the Adams T13 is crucial to decipher between them. And also, if we are dealing with HUS, there's typical, atypical. So atypical is usually the E. coli, sugar toxin, and so on associated. But with the atypical, you can have a lot of different kind of conditions that can cause, like you had mentioned, malignancies could cause it, HIV could cause it, Solid organ transplants could also cause it too. And there also could be hematopoietic stem cell disorders that could cause it, and some other things that could possibly potentiate it. But with TTP, similar sort of things could present in this manner as well. So I think there's a pattern evolving in the patient, but there's something in the background that is driving. We kind of have to decipher what is in the forefront and what is in the background causing this. So it's interesting, the journey has gone from this ultiminal status and this pinpoint pupils, which is creating a lot of discussion in the chat, is interesting. And I like the differential that people have mentioned. It definitely does warrant looking in the head, so getting imaging in the head and possibly an MRI if you want to make sure there's nothing cognitively going on with this patient. Back to you, Francisco. Any other ideas, Sosan, Johan? There's a lot to kind of dwell on here, but we'll swing the mic back to Francisco for the next valid one.
Amazing, guys. So I felt just like you. So basically, we have an hemolytic anemia with hypoproliferation. Very counterintuitive, as Joan said. Great discussion. You're always one step ahead. You guys are amazing. So CT at chest, abdomen, pelvis didn't show any abnormality. And then of course, a lot of you were asking for the smear, and it showed marked anisopoikilocytosis with many teardrops, nucleated red blood cells, and they were very specific in something, which was no schizocytes, no schizocytosis. And then we calculated the plasmic score, which was 6, which showed 72% risk of TTP. PT was 1.3, PTT 24.5 under normal limits. Fibrinogen 340, complement levels were normal. There was ANA positivity and antibodies, anti-DNA, RNP, SSA, rheumatoid factor, anti-citromere, scleroderma, JO1, RNP, they were all negative. And then we got an Adams TF13 level, which showed 54%. I believe the normal cutoff is around like 57, 58. So very mildly low. So I think that you guys can discuss now, and then I won't reveal the diagnosis on the next aliquot, but I think we can make significant progress.
Johan, you want to start this time?
Of course. So, I mean, that's a rich aliquot once again. And I'll start, the first thing I see here is the Adams 13 level, which is low. I mean, I think that's an indicator. I mean, it pushed me more toward TTP again. And the smear is really interesting as well, because I think anisopoikilocytosis is really common in bone marrow infiltration. So when I think about bone marrow infiltration, I mean, you have different causes that can lead to bone marrow infiltration. So, I mean, it might be a cancer, a liquid cancer, or a solid cancer. It might be fibrosis. It might also be granulomas like TB or sarcoidosis, or it might also be histiocytosis, for example. So HLH or Gaucher or Langerhans cell histiocytosis. So these are the different things that I have in mind, because the presentation of this patient is so particular. So we cannot, let's say, even though we are leaning toward TTP, there's something else happening, because the reticulocyte count is low. So there might be two completely different phenomena that is happening at the same time, and we have to keep that in mind. So Adams 13 is low, so I'll still have TTP in the back of my mind and really high on my differential. And the smear showed me anisopoikilocytosis, which is teardrop cells, which is really specific of bone marrow infiltration. So I'll also keep my bone marrow infiltration schema in mind when I continue with taking care of this patient. So what do you think, Sausan?
Oh, yeah, I completely agree with you, and I have like similar thoughts. Just like about the peripheral smear for not showing schistocytes, I think that does not completely rule out TTP, and maybe like we can repeat the smear. And what else? Yeah, and I also think about something is infiltrating the bone marrow. So I'm not sure if we could, if this indicates for a bone marrow biopsy, and maybe we should investigate for some other causes that you mentioned that could infiltrate the bone marrow, like whether it was HIV or other granulomatous disorders. And what else? B12 levels. Yeah, that's where I'm at right now. What do you think, Dr. Ravi?
Oh, I just applaud both of you. You're not sort of been detracted from the argument that, okay, one of these MAHAs, namely TTP, I think up to 30% of the time you may not have schistocytes, so you still got to look for those schistocytes. And many times on VMR, we've seen that the initial labs don't point towards your initial leading hypothesis, but repeating labs, because these patients aren't static. They're not just coming with like one episode or that moment in time declaring everything. These illnesses are sort of they're moving along a spectrum, and at time zero they may not manifest with the schistocytes and so on. Maybe at 1 hour, 2 hour mark they may manifest and declare themselves. So I think it's crucial to probably repeat it, and also know that in this case you could have a certain number of patients not having the typical manifestations. The plasmic score is elevated. The Adams T13 is slightly low, and that also, like any variable, can increase up or down. So repeating it is crucial. But then also shifting your focus to the smear and seeing all these other morphologies of red blood cells. I thought that was a wonderful thought. Trying to go back to, I think it's histopathology and also hematology, how RBCs are formed and then how they may be distorted. So what was interesting, teardrop cells used to be known as dacrocytosis. So they're dacrocytes. And in this case, it could be a signal, like you had mentioned, for granulomatous disease. I love this theory of bone marrow infiltration. So when managing this patient, of course, you want to continue to stabilize the patient, but also then try and decipher what is going on. And maybe, like you, San had mentioned, looking in the bone marrow could be the clue. And now, with the macrocytosis, could this be MDS? Could this be another sort of hematological condition? I'm not sure. I mean, you could open the textbook and have 20 differentials for this. But I think needing help with such a patient, getting hematology on board, and then having a long discussion, meanwhile doing the testing, will be important for this case. Any other thoughts, Osan, Johan, before we move back to Francisco? No, you're doing a wonderful job. Excellent. All right, Francisco, and you're also doing, I applaud you for a wonderful presentation. You're just presenting all the relevant details in such a nice manner. Excellent job.
Thanks so much, Ravi. Yeah, excellent discussion. Basically, something is wrong with the bone marrow, and currently we are like, let's say day 2 or day 3 of MICU course, getting hematology involved, and sometime before we ordered vitamin B12 deficient, vitamin B12 level, MMA, and homocysteine. And methylmalonic acid was high, 2.6, homocysteine was 48.5, and B12 level was undetectable. When we saw this, we started aggressive vitamin B12 deficiency, intramuscular for 7 days. That's what is recommended. And then the cytopenias usually get better after 4 to 6 weeks. That's when we start to seeing an improvement. After some transfusions, the hemoglobin stabilized at around 7. And as the patient started getting less weak, our creatinine went back to baseline. And the Adams TS13 is actually a very good thought, and we engage in discussions with hematology. And we saw a lot of Kirtan cases where we see that a lab is normal, and then we are thinking, okay, is it really normal? Should we repeat it? I think the way you propose to repeating labs is also very important. They were pretty convinced this was B12 deficiency, and kind of the absence of schizocytes kind of excludes MAHA. So now the question for the last aliquot is basically what is causing these B12 deficiency. So in the next aliquot, I will reveal the diagnosis.
Sosan, you want to start with this?
Okay, so we're having B12 deficiency, and now we're trying to look for an underlying cause for it. Just maybe starting with reviewing the patient's history, asking about her nutritional status, maybe, and looking at her medications, what kind of medications can cause B12 deficiency. I see metformin, it could be related to that. I'm not sure if methadone causes B12, but I know about metformin. And maybe thinking other things affecting the absorption of B12, whether it was something in the terminal ileum, having pernicious anemia. Those are my thoughts for now. What do you think, Johan?
Well, I completely agree with you, Sausan. I think that, I mean, if we have to go through basically the causes of B12 deficiency, we have metformin. I mean, people taking metformin. You have autoimmune gastritis. You have pancreatitis. You have diphtheria and botulism. I mean, we have so many causes. But I think in this patient, the fact that the patient is taking metformin is a big clue for B12 deficiency. So I completely agree with you. So I will lean toward that. And I mean, definitely the B12 deficiency explains a lot of things as well, because I mean, the fact that the B12 is low can lead to other type of decrease in other type of side of cells. So cytopenias, as we have in this patient. And the fact that the patient is improving is a good sign overall regarding the bone marrow. So yeah, overall, I agree totally with you, Sausan, with metformin. What do you think, Dr. Ravi?
Oh, again, I think you've done a wonderful job of outlining the causes here. The causes, I think it's pretty much probably staring us in the face, the medication. So metformin is definitely a case. And now kind of going back, if you think about it, you do a evaluation of your breakdown of this case, with the macrocytosis, for a lot of macrocytosis, we do a lot of B12 folic acid. Usually it's not positive, but it's one of the most commonly ordered tests by interns and residents. But in this case, it's ideal because you have hemolysis, you can have massive intramedullary hemolysis in this case as well. And it's always important, especially for the board exam, ABI board exam, doing at least the homocysteine test as well. And the MMA as well. It's crucial because sometimes you can have normal B12 levels, and the MMA may actually indicate that you have B12 deficiency. Although the patient didn't have neurological manifestations, but that could be later in the course. They start having the posterior column associated disease. But this was significant intramedullary hematopoiesis, intramedullary hemolysis, causing such a devastating presentation. But I think, one of my favorite ones, there's been posters recently, and we've had this whippet-induced B12 deficiency quite a few times on VMR, and also many posters have been done about it, which is impressive with the toxic inhalation of whippets, which you can buy actually on Amazon, and that could be a cause too. So be on the lookout for that as well, as it's an increasingly popular use of substance. But here, I mean, I'm interested in the metformin, seeing if that, being on the medication list, if that's causing the B12 deficiency. Anything else, Sosan, Johan, before you move on? No. But yeah, you've done a wonderful outline of all the possible causes, and one of them will possibly responsible. So back to you, Francisco.
Great, great discussion. So basically, you guys, like right on the second aliquot, were able to reach a diagnosis. But that's even though the patient was very poorly complying with metformin. It's a very reasonable explanation. But then, unfortunately, the patient started feeling better, and she left AMA. But as all patients that leave AMA, sometimes we are so curious that. Then there are some labs pending, so I checked her labs later on, and she did have a gastric parietal cell IgG positive and also an intrinsic factor antibody that was positive. There was no history of IBD, no history of prior surgeries like gastric bypass. So we can actually make the final diagnosis of what we call the pseudo TMA induced by B12 deficiency in the setting of pernicious anemia. And you guys did a tremendous job. To tell me your thoughts, and then I can also share mine. But yeah, very special case.
What do you think, Sosa?
Wow, honestly, such an interesting case, and this is the first time I see a diagnosis of pseudo TMA. So I feel like I need to read a lot about this, but it was very interesting and walking through the journey how we started with altered mental status and generalized weakness and ending up with vitamin B12 deficiency. It's truly humbling, and I truly enjoyed the journey with Johan. You did an amazing job, and thank you, Dr. Ravi, for sharing, for supporting us, and Francisco for sharing this case.
Johan, go ahead.
Well, what an amazing educational case. I mean, each aliquot was full of teaching points and full of challenges. As an early, young learner and future resident, I'm just so happy to discuss cases like this. I've learned a lot, from AMS to ending up with B12 deficiency due to pernicious anemia, and the fact that we're actually able to go through the differential of so many conditions. It's so rewarding. I had a really great time discussing the case with you, Sausan and Dr. Ravi, and thank you so much, Francisco, for this amazing case, and thank you Cleveland Clinic for this for the amazing job you're doing. Really happy to be discussing this case.
Yeah, I just want to echo what both Sosan and Johan mentioned. I love this term, Francisco, this pseudo-thrombotic microangiopathy. So the platelets were so devastatingly low that this condition with B12 deficiency, it just disrupts the bone marrow, and then I guess the bone marrow is so in such a disarray that you don't get proper platelet production in this case as well. So yeah, this definitely is a mimicker of TMA, and I think again, just sort of harking back, that this is a patient we tend to, what I've seen is, and we have to pay attention to patients with substance use disorder and not dwelling on this or anchoring on this as a possible cause, but moving on beyond that and understanding that they could have everything like a regular patient can have. So I applaud you for doing your due diligence, ordering all the tests and finding an answer for this patient. Very unfortunate patient left AMA, but hopefully the patient does seek some assistance later and get some treatment for this. But wonderful case presentation, Francisco.
Thank you so much, everyone. Actually, the patient is still getting the injections on outpatient basis. So very rewarding for us. We were really worried about the patient. And when I was thinking about this case, maybe I can share some thoughts. I immediately thought about Rabi when he gave us that amazing Academy VMR probably 1 year ago about the difference between TMA and MAHA. Probably most of you remember that one. Where, okay, maybe we don't have MAHA, we don't have schizocytes, but we can have TMAs without MAHA. And we even had a couple of cases like this, and scleroderma renal crisis is a good example of that, and they developed MAHA a little bit later. I think this is also a very humbling case because, we think about AKI, altered mental status, hemolytic anemia, and we start thinking, okay, what is the one cause that is explaining everything? Is it TMA? But actually, this case is very interesting because we had the altered mental status explained by the opioid intoxication. The AKI resolved in like 2 days, so most likely pre-renal, and the hemolytic anemia also. And I think what Ravi mentioned about the intramedullary hemolysis was also two keywords, because we see what it's called a disproportionately elevated LDH, showing that there's clearly something not only wrong with the marrow, but there's also hemolysis in there. So that was also very rewarding. Then I also learned about opioid-induced TMA. Opioids can induce TMAs, one of the most common causes, like cocaine, of drug-induced thrombotic microangiopathies. And actually, then, I was reading and I didn't have a clear answer for this, but some people call this pseudo TMA, which I believe is a good explanation, but other people call it metabolic induced TMA, because there's some theory that, the homocysteine can induce some microvessel disease and actually start creating develop a MAHA. And so we are between the pseudo TMA and the metabolic induced TMA. That's also an interesting thought. And the last teaching point is that B12 can be normal, because there are a lot of reports, especially in the literature, that when patients have pernicious anemia, there is some like cross reactivity between the antibodies, and B12 can actually be normal, even though it's very, very low. So always get on methylmalonic acid and homocysteine. So I learned a lot, not only studying this case, but also now from you guys, the way you approach this, and you like right on the second aliquot, you were thinking about B12. So very inspiring. And yeah, like Yas said, feel free to ask us questions about the program. Each of us can share what we love most about the program, and about Cleveland in general. So thank you so much for being here, guys.
No, thank you so much, Francisco. Honestly, this is something that we really look forward with these sessions, not only the residency VMR, but in general. Like, I think that having bread and butter cases, again, we like CBRAS, but we also like, as our Dr. Andrew most recently on his podcast mentioned, having a uncommon presentation of a common diagnosis is something that helps us see too. And again, thank you so much for helping us like remember anchoring biases, cognitive biases, and how that can affect our diagnostic process. That's very important for us. And again, it's really amazing to hear how you take care of this patient and your all the process you made. And you're an intern, so the first question will be like, how has your experience as a PGY1 has been in Cleveland, and how does the program help you like integrate into the social and clinical life of being an intern?
Yeah, thank you so much for the question. My experience has been amazing. I'm very biased because since day one, I'm basically, and the easiest way to describe this is that when you wake up every day and you feel so much energy and so much happiness for going to work. So that's how I feel every day, genuinely. I think the program does a very good job with all the way we have so much diversity within the program. And I'm not just talking about IMGs, but even the AMGs being from so much diverse backgrounds. It's very easy to connect with people. I think the curriculum chiefs, the scheduling chiefs, all the chiefs make a very good job. And, we start with 2 interns in the first couple of months on the floors. We are not overwhelmed with work. We adapt slowly. And then after 2 or 3 months, then we are kind of left by ourselves, of course, always with the senior. And then we are able to grow with supervision. That's amazing. And secondly, I would say in every interaction, like with fellows, in Cleveland Clinic, we have an expert in almost every field, and I think people show great passion, and in every interaction they want to teach us. So that's what I love the most, I would say, and not only the chiefs, the program in general, but like the institution and even people at the residency outside of CCF. The focus on teaching is great, and yeah, I'm of course biased as a PGY1. Maybe the chiefs and the PD Dr. Bertano can also make some comments.
So yes, I think the chiefs are present. I am present. You should have told us to log out and then ask him the question, right? What's he gonna say? He's on service with me, right? So tomorrow we round together. So the chiefs should give him a day off because of this answer. But no, Francisco is absolutely phenomenal, and we love him, and we are so happy that he's here with us. And I'm so happy that he's with me on my service rotation, because actually they teach me every day. Francisco and his senior Ahmad is absolutely phenomenal. And I also would like to thank the chiefs for absolutely the phenomenal job they do. Not only for the residents, for the program, for me, for all the attendings. I think without them, we would not exist. We would not be able to function. So thank you again, Mo, Jan, and all the other chiefs. You know, Brandon and Michael and Mariah are absolutely phenomenal. So thank you again.
No, thank you so much. And something that I would really like to know about is Dr. Mohammed, Dr. Ian. Now that you're also like fellows, you're moving on to the next step. How has your experience been with this?
Yeah, absolutely. Ian, do you want to go first, or do you want me to start?
Go for it. Take it away.
All right. So first of all, I'm very proud of Francisco and Johan and sorry, I'm on service, so I just
you got
have
a
to look at the phone.
pager.
All right.
So I forgot
Yeah.
Joe. How could I forget Joe? Joe is covering all my clinics. So thank you, Joe. My
Yes.
sixth chief. So I can tell you they are absolutely phenomenal. And 5 of them go to cardiology, and Mariah goes to hematology oncology. So congratulations again.
Definitely.
Mo, do you need to answer the page?
No, I'm okay. So yeah,
Okay.
first, so Sausan and Johan, fantastic job. This was really really amazing discussion, and I really congratulate you on everything that that you do. So for the program, and my experience here, I feel that the program, I would summarize it by saying I'm prepared. I'm prepared for what's to come, whether that's taking on a job. So as chiefs, we can staff the inpatient services. I'm on service right now. We also can moonlight by ourselves, and we staff in outpatient clinics as well. And I feel ready that I can take on the challenge. And I also feel ready to start my fellowship training. That doesn't mean by any means that we know all of the cardiology that we need to know. But it means that we learned in this program by how much we value clinical reasoning, how to ask the right questions and how to take the correct approach, how to have our system 1 and system 2 cognitive systems working at the same time, as Dr. Ravi was mentioning. Sure, you want to be doing the cognitive thinking, but are you also stabilizing the patient at the same time? And this is something we pick up very quickly here at the clinic when we respond to rapid responses, whether that's real rapid responses or mock rapid responses that we respond to, or whether it's a case that we're discussing during table rounds. So that would be something that I'm always going to remember.
Thank you so much for that, being like humble, but also knowing that you can do the job and you have that, like, you understand how much you know, but also not being biased. That's, I think, very important as whenever you go into that state. And Dr. Ian, how about your experience?
Yeah, so first off, I'll tell you, Mo is being very humble. He was probably ready to be an attending even before he started residency, if we're being honest. But I think just for myself, it's really an incredible experience coming from New York. This was a big change for my family and I. Obviously, not international, like coming from Jordan or South America or Europe, but definitely just a new experience. And really, the people I met here are family. Dr. Bertano is basically like my PCP and father at the same time. It's really just like a warm environment. And then when you just see the breadth and depth of all the experts that you rotate with, that write the guidelines, that you see their names on TV or in documentaries, you think they're going to be these people in these ivory towers that you're never going to see, and then all of a sudden you're walking the hallway and they give you a hug and they're like, "Oh, you did great on the service." So it's really like a family experience, and just the diagnostic skills you learn here are incredible. So for me, incredible growth. I really do feel prepared for the next steps. I feel incredibly lucky to have trained here.
Thank you so much for that. It's really important for us to have all those insights. And I also have a question for Dr. Bertano. I think that listening to all these amazing experiences, and I'm sure that they are not saying this because you're here, but because I would definitely love to know, and I think that many are questioning themselves, like how can a candidate aspire to be part of your program?
So, first of all, I would like to thank you again for this amazing presentation. Actually, it was absolutely fascinating. I didn't know the case ahead of time. I would love to listen to more of these podcasts, and I'm pretty sure the residents will advertise to the residents. They really will learn a lot from those presentations. So I want to emphasize again, I get this, first of all, the question when the candidates come for the interview, why did I stay here? And I can tell you the number one reason why I stayed here is the residents, because I learn from them every day. So I wanted to be very clear that that's what the chief said. It really feels like a family. We have a huge program, so we have around 184 residents. So it's a big program, but it really feels like a family. So how can you become part of our family? It's a complex process, because you know very well the recruitment is difficult for the candidates. It's complex for us. We have around 5,000-6,000 candidates applying every year. This year we had exactly the same. We interviewed this year 600 candidates, and unfortunately from these 600, we only have 56 positions this year. We usually have 55. This year we have 56 to match. So I think it's important for the candidates to find out if their values align with our values. Because what they can find here, they can find absolutely what the chief said, everything, right? So they have clinical training in every subspecialty, in everything they can dream of. They can do research with all these phenomenal people that are here. They can see a wide variety of pathology, but it's also a very demanding environment, right? I mean, you have patients, you have a lot of rotations, you have calls and so on. And it depends what you are looking for. So you have to talk to us. You have to talk to our residents. You have to talk to our attendings, and then find out, are you interested or not, your values compared to our values. Apply, and then that's how you can get in. If you are interested in medicine, please apply. Yes, we'll review every single application. We reviewed every single application of those 6,000. Every person was reviewed. Every single document was reviewed. We had an army of attendings, and the chiefs helped us tremendously. It's difficult, but that's the only way.
No, and thank you so much. I think that the closest experience we've heard from CP Solvers is Dr. Ravi, that he's also a PD, and listening to all of you, all of your team as program directors and APDs, reviewing every single application and document, that's something that we are very thankful for. And again, thank you for your insights of how to apply. I mean, we know that as IMGs, we already have the no. Maybe we can get the yes. So that's something that, thank you so much for that, for reviewing every single document, honestly.
And we review with human beings. We still don't use the AI to review the application. So, yeah.
Oh wow, that's even more. I think it adds a lot. It adds a lot to the amount of work, and that's, I think, nowadays something that's the most valuable. And again, I think that to be mindful of your time, the last question would be how you like Cleveland, Francisco. Like, how is living in Cleveland?
Oh, it's great. So, I was very surprised by the cultural opportunity. So my parents were visiting me, and what am I going to do with them, right? And so we went to the Playhouse Square, which is the second biggest theater district after Broadway in New York. We watched this orchestra with and we at the same time as the orchestra was playing, we were seeing the Spider-Man movie. Amazing experience. Then we have the Cleveland Orchestra, which we were discussing yesterday with Dr. Bertano. Is apparently like the second one of like five best in the world. So also that. Then we have, of course, American football. I've been like to 3 games of the Cavs, and then like I'm on 2 soccer tournaments around Cleveland. One with the PGY ones, and the other one with some guys that I met at the shawarma place. So they so so a lot of opportunities to do sports, cultural activities. Actually, there's a beach too. So of course not like the Portuguese ones, but there's a beach, there's a lake. So I was very, very surprised. Well, not Lisbon, but I think you'll have a great time.
That's really amazing. I can just imagine you making friends in the shawarma place. That's I think that very on point of the kind of person you are, Francisco. And Dr. Ian, it's okay. Again, if you need to go log off for your dad duties, that's completely fine. Thank you so much for this, Dr. Muhammad. I think that there's a question, the last one for the before you leave. Vinny asks, like the tracks that the program offers, such as hospitalist track, clinical scholar programs, and clinician educator. I know that Dr. Mo is one of them. So
Yeah, absolutely. I'm happy to comment on the tracks. I actually continued my entire training in the categorical track. So I took the regular track through my 3 years, and I had a fantastic experience. So, but our program does offer certain tracks if you have a certain interest that you want to focus on a little bit. 2 of those tracks you have to apply to through ERAS and match into. And then 3 of those tracks you can apply in your PGY1, and then you start that track in your PGY2 and 3. So the ones you apply to through ERAS, that's your clinician educator track, and that is your VA track. So the clinician educator track focuses on those who look to be clinicians who are also educators. So you will still have the same clinical experience, but for certain periods of time, you will have some protected time where you're getting didactics related to medical education and adult learning theories and so on. And then you get the opportunities to practice some of these skills that you have done through curriculum development and then delivery. So that's what the CET track does. The VA track, what that entails is that your primary care experience, and I will repeat that again, only your primary care experience will be at the VA instead of being at the Cleveland Clinic Primary Care Institute. And it's usually clustered into 3-month and then 6-month and then 3-month blocks into your PGY1, PGY2, and PGY3 respectively. And that's what makes that track unique. While the categorical track, to compare that, is an X plus Y system where you have your 4 weeks of non-primary care and then 1 week of primary care. By non-primary care, I mean you could be on inpatient, you could be on subspecialty outpatient, and so on, or consults. As for the tracks you apply to once you're in the residency, so the hospital medicine track is a track that is geared towards 2 goals. Number 1, it teaches you how to be a hospitalist. So you rotate with a hospitalist, but instead of rounding together for all of the patients, what you do is you split the list with that hospitalist, and then you see your own patients, and then you meet again so that you can discuss the cases. That's for half of the time you're doing the protected hospital medicine track time, and then the other half you're getting education on hospital operations and leadership and finances, so that if you are interested in a career in hospital leadership as well. You can, of course, go into the hospital medicine track and match into fellowship, or you can stay and do hospital medicine as well. So Joe, for example, one of our chief residents, was in the hospital medicine track, and he just matched into cardiology as well. As you notice, there's 5 of the 6 chiefs matched into cardiology this year, and our 6th chief, Mariah, is going into Hemat. So that's the hospital medicine track. There's also the ClinScope, or the clinician. That's the track that is geared towards research. So again, you will also have the same clinical experience, but you will also have additional protected time to do research during that track, and also learn the research methodology properly by really top-notch researchers in the clinic. And that's geared towards those who want to explore if they want to be a physician scientist moving forward. So that's the hospital. And then finally is the primary care track. The primary care track is for those who are interested in doing primary care, and it just gives you a little more time in the primary care setting. So you, instead of just having the 4+1, you will have additional blocks of primary care that you can do. So these are the 5 tracks that we offer, in addition to the categorical track that everybody can also be in.
Thank you so much. I can tell that you were a really good chief resident. You explained everything so concisely, and literally it shows how much Cleveland Clinic prepares you for everything, like even finances for hospitalists, and it gives you like your own patients to feel like the real deal. That is something that that experience is like invaluable. So I think that thank you so much for coming here and explaining to us absolutely everything in so much detail, but also so like precise. Again, being very mindful of your time. Thank you, Dr. Patano.
Thank you so much.
And if any of your residents want to come here, present any day of the week, VMR goes on YouTube every single day. We also have the podcast. So again, we love to share this like passion for clinical reasoning. Francisco, you are amazing. I really hope that you keep shining, and thank you for this Saturday.
Thank you so much.
Thank you, everyone.
Thank you so much. And I will be in touch, Yaz.
Thank you so much. See you later.
See you.
Take care and have a great Saturday, sorry. Bye.